everyone, welcome to a new episode of Retina Chats. I'm Mohammed Ghunaim and with me Dr. Mustafa Manhali.
Hello, everybody.
Today I will be discussing a rather painful experience and a painful experience in retinal surgery and retinal detachment. So first of all, this is a case presenting to me. It's a 30-year-old patient with acute PVD. And we can see here there's multiple retinal breaks. There's a large retinal break at the superior temporal area. And there were also some retinal breaks at the inferior part. So first of all, how would you manage this case?
So it's a macula on detachment in a young age. So probably it's going to be a straightforward scleral buckle,
Okay.
especially with inferior tears. So I prefer to go for scleral buckle rather than vitrectomy.
Okay, so that's what I did. I did a scleral buckle, and would you do a drainage procedure in this case?
Actually, the detachment is not that high, so I won't drain in this case.
Okay, so yeah, I didn't drain. I did a cryoretinopexy and I did an encircling band and tire, and he actually went very well. Vision was okay. Macula was attached for around 3 to 4 weeks, and then he came to me with a recurrent retinal detachment. He has a lot of vitreous haze. So how would you manage this case?
Is it a recurrence from the same tear?
Yes, the same tear, the same superior temporal tear is now open, and there are other new tears that weren't there in the first surgery that appeared here in the inferior nasal area. These weren't there, and the same tear, the superior temporal one, had an open is open now, and there is subretinal fluid reaching the macula.
So probably in this case, with this young age and multiple tears, and there are some peripheral degeneration. So I think there is some sort of vitreoretinopathy in this case. So this is not a regular.
He's a high
case.
myopic. He's high myopic.
Probably this one of the causes, but it is not an only cause for this kind of detachment. So for your question, I would definitely go for vitrectomy with this enlarged large superior horseshoe tear, and even over the buccal to be have this kind of acute PVD to even pull the already tamponated or already buccal tear, and it was stable for 3 to 4 weeks. So yeah, I definitely will go for vitrectomy as you
Okay,
did.
so I did the vitrectomy, and then here I noticed there is a fine immature membrane that I tried to remove, and it was successful to remove. But I still feel there is a sense that there is something wrong in the macula. There's some pigments, but I said, okay, no problem. I'll just leave it to be and observe the patient. I hear I'm doing fluid air exchange. I didn't put any PFC and lasering the brake. So the $1 million question: what tamponade would you use?
For me, I would use gas,
Okay.
SF6, around 12 to 16%.
Okay, so here I use silicone oil. Okay, for many reasons, I feel that the eye has a tendency to produce membranes, and I'm also more reluctant to leave patients who are recurrent cases on gas. I prefer to play it safe and put silicone oil. So I decided to leave this patient on silicone oil. Here I'm lasering the tear, and you can see the cryo marks are there, and they're well positioned. Here I'm lasering the new tears that weren't there in the first surgery, and I'm leaving silicone oil. Okay. So would you do anything more in this surgery? Do you have any comments? Would you do an extra step that I didn't do here?
Actually, I would do some staining with BBG
Identify any
to
hidden-
highlight, yeah, if there is any membranes over the retina, whether there are some PVR that are hidden that I should peel in the first surgery. Especially, I tend to use the gas in the second surgery rather than silicone,
Okay.
especially for upper tears like this with already encircling band
Yeah.
in these eyes.
I here stayed with triamcinolone. I didn't feel that there was much more going on, and I didn't need to add BPG. I added silicone oil. The patient was again doing fine for around a month, and then he came with another recurrence. Okay, so he developed a lot of membranes, and as you can see here, the after removing silicone oil, the retina is almost completely detached. So, what do you believe is the cause of this recurrence?
I still believe this is not regular retinal rhegmatogenous retinal detachment. There is some syndromatic cause or a vitreoretinopathy that is hidden in this case.
Okay.
And even under silicon to have this kind of PVR, probably there are some vitreous cases that was not highlighted in the first surgery or the second one. So to have this kind of detachment after stability for 1 month after the buckle, then silicone, then we have another detachment with this kind of PVR grade C with star folds. So could tears, large tears do this, but you have already tamponaded with a buckle and then you added the silicone.
Okay.
So
So here, yeah, I stained with BBG now, and I'm here peeling the thick membranes that developed just in under 2 to 3 weeks. So this is one of the points that you were highlighting, that this could be an abnormal vitreous, abnormal vitreous and a syndromatic eye. There were also some peripheral star folds that I'm peeling.
I think there a new tear.
This is the one of the original tears that had opened. Yeah, it's not no, it's
so it's
adjacent to the new tear. Here I removed the membrane and then staining again with BBG, and then adding PFCL to flatten the posterior pole. Would you go for peeling healthy ILM? Do you believe that peeling ILM decreases the incidence of recurrence of a membrane?
it actually it did it decreases the membranes over the macula, yes. And in this case I don't do it regularly in regular detachment cases.
But in
uh,
PVR
in this
detachments,
case with
yeah.
the current detachment, yes, I will definitely go for ILM peeling.
Okay, so you can see here that this ILM is not that diseased, but I opted for removing this ILM because it's just adjacent to the membranes, and in the third surgery you're trying to do
The maximum you
yeah,
can do,
as
yes.
much as possible, and you're trying to do whatever you want, that would prevent recurrence. Okay, so now the PFC bubble attached the posterior pole, but the periphery is still detached. Would you do anything else? When what's the cutoff point that you say, okay, now I will do a retinectomy?
No, this is not a case for retinectomy because first that the retina is still mobile. There is
Okay,
no shortening that you can see. That if you increase this bubble of the PFCL,
it
it's
will
going to
flatten
flatten,
more.
yes. And there
Okay,
is a false test for this if you try to do it under air, because air is a very pushing
exactly,
force
yeah.
that will stretch the retina. Even if there is shortening, it will stretch the retina. So don't try to do this under air, but in under PFCL, it can show if there is shortening or if this retina require retinectomy or not. But in this case, if you removed all the membrane, I think it can relax down and you
Yes,
don't need to
exactly.
add.
So here I
And this
didn't.
is, and let me add, this is one of the advantage that you had a previous buckle in this case, which will minimize
Yes.
the risk of doing
Okay, so
retinectomy.
yeah, I didn't do a retinectomy here, but I'm just asking you to know what's the cutoff point or what's your threshold for doing a retinectomy. For me, I decide whether to do a retinectomy or not is by the appearance of the retina under the PFC. If I find that under PFC or under the edge of PFCL, there is some retinal some subretinal fluid, then this retina is shortened. If I find it flat and I can see like here the choroidal vasculature very clearly, there is no subretinal fluid whatsoever, then I believe this retina will flatten under silicone oil in the post-operative
This
period.
is a good point.
Here, okay, I'm going to do a fluid air exchange, drain from the inferior breaks, and I know you would have done a gas in the first surgery. Here, what would you do? Silicone or gas again?
After this kind of PVR, I will add silicone. This is
Okay.
the third surgery for me.
Yes, I added silicone oil, more laser, and this is one of the cases that
I think
we see.
one of the challenges in this case that may cause these recurrences, especially after the third surgery and under silicone, there are some residual vitreous at the periphery, at the aura, and we cannot remove all the vitreous from this
Because of
peripheral
the
retina because of
adherence. Yeah.
detachment. But what I found recently that using the 25 gauge cutter, especially under air, you can trim these peripheral vitreous and it minimizes the rate of recurrences in these kind of myopic detachments, and it really salvage the glow from recurrent vitrectomies and retinectomy, especially if you had this buckle before.
Okay, so I didn't show you here the vitreous removal
Shaving.
under air on shaving, but believe me, after third surgery, there is not enough vitreous to be removed. But this kind of situation that we see in vitreoretinal surgery, and we have to deal with. So tell me more about how you deal with these patients psychologically. How do you manage their expectations? How do you talk to them before and after
This is a
surgery?
very hard point to tackle,
Address.
or yeah, or elaborate with those patients, because they are a productive age group. They have a lot of things to do during working, their lifetime, their family. So they are crippled at this point of life, whether they are under the surgeries or under these recurrent bad news about detachments. So they actually require a long time of counseling in the clinic, and you explain that this is not the common scenario and the risk of redetachment is there,
Okay.
and we have to further investigate even to salvage or to protect the other eye, because it's a high possibility to have this bad scenario in the other eye.
Yeah, exactly. So we have to talk to our patients as much as possible, counsel them. The psychological factor is one of the important factors that we could forget about during
Mm.
these surgeries and during the post-operative counseling, but it's really important. Okay, let me ask you a final question. In retrospect, would you believe that if you did a vitrectomy from start in this patient, would it have a better result rather than a buckle?
For me, definitely no.
You will still do a buckle. You won't.
Yeah,
Uh,
if you have a young age, no PVD, we have an attached vitreous, no history of trauma, high myope, superior temporal tear with a shallow detachment. So this is, I think this is the best indication for a scleral buckling. And if you did this vitrectomy from the beginning, I think you would had a large area of retinectomy in the second surgery.
mm.
So no, I think what you have done, this is the same what I have done in such a case.
It's I know that what you're saying is correct, but you can't just stop thinking that what you did wrong in this case. Yeah, I know that it's the standard of care to do a buckle in these young age and not to do a vitrectomy from the start. But you just can't stop thinking that what did I do wrong? Do you have this feeling sometimes with your cases?
Sure, definitely. I will keep searching what is wrong in this case to avoid in other cases, but sometimes it's the fate of this case.
Yeah,
It's not your mistake.
exactly. Okay, so this is the conclusion of our episode. Thank you very much for watching. Stay tuned for the next one.
Thank you.